Hi everyone, my name is Iris, Chairman of the Emergency Physician at Miramore Hospital. I've got Kiriana, one of the medical students, with me doing a summer studentship. So we have done a alcohol screening in the emergency department as part of the summer studentship, and we would like to present our data. So first of all, I think we should just give some background information as to why we did this study. So in New Zealand, we have a drinking culture that actually have easy access to alcohol, encourage alcohol drinking, and actually normalises heavy drinking in the community. Studies have shown that there's actually about 7.5% of all ED presentations are alcohol related. Now, from the 1st of July 2017, which is going to be less than a month away, the Minister of Health will be requiring us to actually present alcohol-related presentations data as part of the mandatory reporting. We have no background as to what our rate is. We do not know what resources we need. We don't know what we are dealing with. So we actually decided that this is a acute severe public health issue, so we need to actually address this, and part of this is that we want to do an alcohol screening and brief intervention as part of an integrated community and hospital program, and this forms the basis of data that tells us what we need to do. So what our study shows, what our study aims are that we want to actually document the alcohol burden in the alcohol-related presentations in the emergency department. We know there are data of overall ministry health alcohol use. We have lots of national data, but what is our counties Manukau health specific data? We also need to actually explore staff perspective in terms of introducing alcohol screening in the emergency department. So this study is a 2-week study that span from 8 a.m. The 5th of December to 8 a.m. The 19th of December, so it's 2016. Involves 2-part screening question, asking, first of all, asking the staff, is alcohol related to this presentation? Yes, it's because of their own drinking, of the patient's own drinking, and yes, others contributing to it, or that this is not an alcohol-related presentation. And the second question is to try to gauge as to how easy it is to reach that conclusion and on what basis. So we actually asked the staff that fill in the questionnaire, well, are they going to go by their history, patient's history, going by clinical judgment, or actually a blood alcohol level? And Kiriana is going to present what we actually find.
Kia ora everyone, my name is Kiriana, I'm a final year medical student. I've spent 2 years at Miramore, so I really enjoyed it here. So this is our flow diagram demonstrating our study Uptake, and as you can see there were 4,363 individual presentations to the ED during our 2-week study period, and we managed to screen 87.8% of them. So this required huge effort on the part of the ED staff members by filling out the questionnaires for each of these presentations, and so we're therefore very grateful for them for that. And then the next point down here is that 9.3% of all presentations to the ED overall were alcohol related for our 2-week study period. At the bottom there we're further stratified by the type of alcohol related presentation. We're in 7.8%, 0.8% and 0.7% of all presentations overall were related to the patient's own drinking, someone else's drinking, or both respectively. So our graphs came out a little bit skewed, but one of the first points of analysis for us was that when these presentations were occurring, we looked at the day of the week and also the ED shifts, so they're 8 a.m. to 4 p.m. for day, 4 p.m. to midnight for afternoon, and midnight to 8 a.m. for night shift. And alcohol-related presentations on weekend days comprise 15% of all presentations, so you can see that there's the increase in the weekends. And as you can also see there is that alcohol-related presentations comprise 7%, 9% and 16% of all presentations overall for day, afternoon and night shifts. There was also an increase in alcohol-related presentations on the Monday morning, which we found was kind of the tail of the Sunday night presentations. The importance of this is that these times have an effect on staff resources, as weekends and night shifts are not as well staffed as the weekdays. As part of our study, we wanted to identify where the inequities, if any, lie. These are important as any intervention to reduce the burden of alcohol-related harm needs to take these into account to be successful. The first inequity issue we identified was that alcohol-related presentations were most commonly attributed to male gender patients. So male patients represented 67% of all alcohol-related presentations, and as you can also see here, the vast majority of patients presented because of their own drinking. The second inequity issue we identified was in the younger age group, and as you can see here, 51%, it kind of comes out funny on the graph, but 51% were due to patients between the ages of 15 to 29 with a greater burden of presentations due to someone else's drinking or both own and someone else's drinking in that age group. And so we thought that identifying this younger age group and where the demographic of alcohol-related presentations lies was important to address in any future intervention. The third inequity issue we identified was with ethnicity. So Counties Manukau Health has a unique multicultural demographic which needs to be considered in any intervention. Alcohol-related presentations were most significant in the Māori population and the European and other population, comprising 30% and 34% respectively, and then Pacific peoples comprised 23%. There was a lesser burden for patients of Asian or Indian ethnicity. So developing an intervention that is both culturally safe and appropriate is very important, particularly for our multicultural population. We also looked at alcohol-related presentations by locality, as you can see here. This will be important when developing the intervention program as it can be better integrated with the relevant community services. This data may also help shape local alcohol policies, which are important, particularly in this population because of the recent events with alcohol licences being granted within metres of school grounds in South Auckland. And then here we have a table showing the types of alcohol-related health harms relevant to our population. So these are the 4 categories: injury-related, self-harm related, acute intoxication and chronic alcohol intake. And as you can see at the bottom, 51% of presentations were injury-related, followed by 24% as a result of acute intoxication, and then chronic alcohol intake and self-harm related are also there as well. So the types of presentations will be useful in the planning of future service provision, as they will need to liaise with other specialties, i.e. psychiatry, if the intervention that is implemented is to be successful. So this is very busy, but this table demonstrates the cost of alcohol-related presentations with a mean cost per presentation of around $3,500 and a total cost for the 2-week study period of around $540,000. So as you can see here, you can also see here the services that were most affected in terms of costs related to alcohol. And we had a lot of discussion about whether to include paediatric populations in our study, but we did, and this was the reason, so that we could identify what age groups or those in the vulnerable population and what kind of presentations they came in with. And as you can see, Māori and Pacific are disproportionately represented here. Staff survey results, very, very quickly. So we also have the results. The uptake of the staff survey was largely by ED nurses. Doctors were less represented. All respondents found our questionnaire either fairly easy or very easy to complete. And then they also identified some of the resources needed to implement screening and brief intervention in the ED. And then here are some of the free text portions of that survey about resources required. I'll pass it back to Iris.
So just to summarise, those are the practical implications of how we're going to be using our data to design an intervention program that will address the cultural and also specific inequities needs, and also to liaise with different services in the community as well as in the hospital specialties to actually identify opportunities to actually do any intervention, and also taking into account of staff resource requirements that we need to develop a program that has capacity, staff capacity, so that it will be successful. Thank you.